be better if you use the Q&A feature. I'd like to introduce Dr. Blaine Hart and Dr. Marc Mabray, who are both radiologists, neuroradiologists from the University of New Mexico Health Sciences. Dr. Hart is a professor emeritus who has been involved in CCM research for more than 20 years, and he continues to remain involved. Dr. Mabray is an assistant professor who is now the lead radiologist for CCM research at UNM. So because of the prevalence of the common Hispanic mutation in New Mexico, these two physicians have read more CCM MRIs than any neuroradiologist in the world. And then they are also the study neuroradiologists for the Brain Vascular Malformations Consortium project, a component of which is more than 10-year natural history study of CCM that's now ongoing and will be going to a 15th year. We are very lucky to have them here today to share their expertise, and I want to hand it over to them. Thank you. Dr. Hart.
Okay, thank you. It's good to be with you today. I know I've met some of you in the past, and it's nice to be with you virtually. I hope that those of you in the West are surviving the extreme weather between heat and cold a few states apart. We're going to talk today about some basics and then some other aspects of imaging, and I'm sure it's something you've all had some experience with. I guess the first question is why do we do this expensive and fancy imaging in the first place? Just to give some overview and outline as we begin. Well, one reason is to establish a diagnosis, especially if there has not been one before. For example, somebody who has a family history and they want to understand, do they have any problems themselves? Another reason would be someone who does not have a previous may or may not have a previous diagnosis, but now has acute symptoms, especially if we suspect acute bleeding. Once we know there's a problem, it may be appropriate to do some follow-up, especially if it's bled in the past, and perhaps to get an idea as to whether there's a more unstable lesion. Following up without acute symptoms is a question that comes up frequently, and I have to say there's not a real clear scientific answer as to how often to do that. That's going to depend very much on the informed clinical opinion of the doctor that's providing the primary care for you. Sometimes we do some different kinds of imaging if surgery is indicated to help plan. We'll talk about that a little bit later. And then finally, there's some value in imaging for research. It may not be of benefit for the individual, but may be a benefit for others who have this disease. There are different techniques available, mostly CT or MRI, although there are some others. And even within those techniques, there are some different ways of doing the imaging. Sometimes it does make a difference. And we'd like to know, are there differences in the malformation? Are some, for example, more prone to bleed than others? CT stands for computed tomography. It's done by, it's basically a very fancy X-ray test done by using a very thin X-ray beam, which the data is then sent to spins around the patient, and that information is fed into a computer, and the result is a reconstruction that looks like a CT scan of a 2D slice of the brain or of the body. The information there is mostly based on density. So bone is white, hair is black, other soft tissue in between. We can get some additional information about blood vessels by actually injecting a contrast material that contains iodine. That is not routinely used for CCM imaging. It might be useful in a few cases, but it's not routine. One advantage of CT is that it's very fast. It typically takes less than a minute to actually do a scan. It takes longer to get the patient into the room, on the table, positioned, and get set up than it does to actually do the scan. It's very widely available. Almost every emergency room would have fairly rapid access to a CT scanner in the United States. It's cheaper than MRI, although I recognize that is relative and it's still not cheap. And I've facing bills for myself, from my family, and looking at the bills, I know it's a real consideration. Disadvantages of CT, first of all, is simply not as good as MRI for looking at the brain. It is an X-ray based technique, which means there is a small dose of radiation. It's not a large dose, but it's something that is there. It's consideration. If an IV contrast material is administered containing iodine, there's a very small chance of an allergic reaction, and in very rare cases, we're talking about 1 in tens of thousands of cases, that can be a very serious reaction. So it's small, but it's a risk that's there. And the IV contrast rarely can damage the kidneys. Mostly that's a concern in someone who already has borderline kidney status. I mentioned this last line with a little bit of hesitation. I don't want to panic people, but we know that large doses of radiation can actually cause cavernous malformations. And by that, I'm talking mostly about radiation therapy, so treatment of cancers by using radiation. That is thousands of times higher dose than a CT scan of the head. So there's a theoretical risk of radiation actually leading to formation of new CCMs. For practical purposes, if there's an urgent reason for a CT scan, I personally would not worry about myself or a family member receiving a scan. It is reasonable to keep in mind, though, that in general, MRI is, for many purposes, going to be better for showing detail of the brain, especially for cavernous malformations. And repeating a lot of CT scans is probably a good idea to avoid that. A typical setting for a CT scan would be if someone has new sudden symptoms that suggest the possibility of a large hemorrhage. So because it's very fast and it is good for showing acute hemorrhage, that would be a typical use in an emergency setting. This is an example of a CT scan. The white area, round white area in the middle of the brain is a large hemorrhage. That can be caused by a number of reasons. You would have no way of knowing from the CT scan alone that there's a cavernous malformation underlying this. CT can also show calcifications. On the left hand of your screen, the small, brighter areas within that are areas of calcium. And some cavernous malformations, not all, but some have calcification present. But small CCMs simply are often not visible at all on CT. The test of choice for most purposes for looking for cavernous malformations is MRI, magnetic resonance imaging. This is done producing two-dimensional cross-section pictures that look in some respects like a CT scan, but the physical basis is completely different. It's done by using a very strong magnet and radio frequency energies, basically radio waves. So there's no ionizing X-rays involved. It depends on the magnetic properties of hydrogen, mostly water. You may not think of it as having magnetic properties, but extremely weak properties can be used to produce images of the brain. Iodine doesn't show up, but if it's necessary, if it's considered appropriate to add the information about blood vessels, then we use a different element called gadolinium. Again, not used routinely, but might have a little more use than with CT. One difference with MRI is that we have lots of different ways of acquiring information. I'll come back to that in a minute. There are some disadvantages. The biggest is that this is a very, very powerful magnetic field, and I'm sure you're aware that there's a risk from metal moving in a magnetic field. If someone were to bring something into the room, it would fly into the magnet. If it were steel or iron, could fly into the magnet and damage someone if it hit them. The small size of the tube can be an issue for people, and claustrophobia is a real problem for some people. It's very noisy to produce the pictures, so headphones or earplugs are always used. It does take longer to acquire than a CT scan, maybe 20 or 30 minutes, occasionally longer. So especially for a child, that can be a real challenge. And even for some adults, it's a challenge to lie still without moving for that long. The chances of a reaction to the contrast material are much lower than with CT scan. There is still some chance. And if there's kidney damage, the gadolinium can very rarely cause problems. It does not actually damage the kidneys the way the iodine contrast can, but it can damage other tissues. This is important mostly so you understand there's a reason for sometimes having tests done to check your kidney function before a scan, either CT or MRI. If they consider there's a possibility you might need contrast material, they would often check your kidney function. Sometimes if it's already been done recently, or if you're young and healthy, they may not feel like they need to do that. Other times they may get a blood test to check that. What are we looking for? These are dilated blood vessels. That's where the cavernous comes from, but that's talking about usually microscopic blood vessels. So they're very small. They've been described as kind of bubbly appearance. The picture you're seeing in the middle is from a surgical specimen that's been taken out. These are blood vessels of different sizes. Sometimes the neurosurgeons or the pathologists compare them to a mulberry in appearance with the multiple reddish balloon-like areas. Of course, on CT or MRI, we don't see color. We see this sort of appearance. And they vary somewhat in appearance, but a somewhat bubbly appearance in the larger ones is common. Well, as I said, with MRI, we have a lot of different options as to how to look at things. And we can do different sequences, unlike CT. And you don't have to worry much about that as the patient. But the radiologist who's setting this up will, in fact, choose from a variety of different ways of looking at the brain. One other thing that's important to consider is the strength of the magnet. Keep in mind that the magnet is always on, unlike TV shows where I've seen, and you may have seen, where someone foils the villain by turning on the magnet. It doesn't work that way. It's always on, very strong. The strength is measured in units called Tesla, and the most common strength used is a 1.5 Tesla magnet. Although 3 Tesla, twice as strong, is also becoming fairly common. There are weaker, less than 1 Tesla or even less that can be used. That's going to be less sensitive to blood, and the stronger magnetic field means quicker imaging. Weaker field is less imaging. The bottom line is that the principle to keep in mind is that there are always some trade-offs. So doing quicker sequences usually means not as much detail, for example. Some of these sequences are more sensitive than other sequences for blood. I'm going to show you an example. This is the one that's probably most commonly used. And there's a large cavernous malformation right here. There's a small one here, a very small one here, the dark spots, black spots. Now this is a different sequence here, gradient recall sequence. Notice that we lose some of the internal detail in the large cavernous malformation, but we're seeing now 8 or 10 additional small lesions. These sequences that are more sensitive for blood have different names: gradient recall, gradient echo, susceptibility weighted, you may hear about. And it doesn't help the confusion here that different manufacturers, Siemens, GE, Philips, of course, they all have to have their different names, each individual for what they use, even though they may be very similar, equivalent. If cavernous malformations are a concern, some kind of blood-sensitive sequence should always be used. Susceptibility weighted is the most sensitive. And here's an example of 3 different sequences all done at the same place in the brain, showing progressively greater number of small CCMs being shown with different sequences. (3T) is going to be somewhat more sensitive than 1.5 Tesla. Susceptibility weighted is the most sensitive, and it has the additional advantage that it shows veins very well. Well, what does it matter? Well, from a scientific standpoint, we'd like to be consistent. And it's important whether we find one versus many. That changes the diagnosis. If there's more than one, it's more likely to be familial. And we want to avoid a false negative. That is, we don't want to miss cavernous malformations. Here's an example. This is a child who presented with no family history. The green arrow is pointing to an area of blood in the spinal cord. He presented with weakness in both legs and pain with no other explanation. We looked at the brain with one of these blood-sensitive sequences, and here's a cavernous malformation in the brain. And the spinal cord turned out to have a cavernous malformation there. So that, having 2 made it very likely that it was familial. And in fact, it turned out that one of the parents, despite having no symptoms ever in the past, also had cavernous malformations. So the take-home message on this is that a blood-sensitive sequence is really important for cavernous malformations. Other sequences should also be used. If you have different results reported on different MRI studies, be careful how you interpret that. Don't panic about that, because the first question is, did they do the same thing? Did they use the same technique? Was it a 1.5 Tesla magnet versus a 3 Tesla magnet? Did one MRI performed using susceptibility weighted imaging? That might show twice as many small ones as in a different sequence. That doesn't mean there are more. It just means there may be technical differences. There are some cavernous malformations associated with developmental venous anomalies, or DVAs. These are variations in the venous structure where there's multiple small branching vessels coming together to drain into one larger vein. And it turns out that there's a clear difference in familial versus sporadic. The familial cases have very little association with a DVA. Patients with sporadic cavernous malformations, there's a very strong association with those being close to a DVA. Here's one example of a young man with no family history. The green arrow is pointing to a cavernous malformation. The yellow arrows are pointing to this fan-like appearance or brush-like appearance of a DVA very close. This is a young woman with no family history. The green arrow is pointing to a cavernous malformation, and there's an unusually large DVA very close by. It does make a difference in terms of surgical approach if that's being considered. And I'm going to turn the time over to Dr. Mabray.
Thank you, Dr. Hart. I'm going to talk a little bit about a few additional techniques that you've probably heard of and may have had done. First is vessel imaging or angiograms. There's a number of different ways to do an angiogram. You can do a CT angiogram, an MR angiogram, or a catheter-based angiogram, which is an invasive test. This image here on screen left is a CT angiogram. In that study, contrast has been injected into the vein, and the study is timed to try and catch that contrast when it's in the arteries. Allows us to look at the arteries, make sure everything looks okay with those. The middle image here is a magnetic resonance angiogram. So that's in the MRI scanner, often done along with a brain MRI, but does not have to be. In this case, we did not use contrast, and we're actually imaging flow within the arteries, create these pretty 3D projections like this. Can be done with contrast as well. A lot of times we'll use contrast if we're also imaging the neck, or rarely in cases of following up treated aneurysms. And this one here is a catheter angiogram. So in this case, one of the neurointerventionalists has put a small catheter or tube into the patient's leg artery and maneuvered that little catheter or tube up into the neck vessels. And then they're injecting contrast while taking a series of x-rays. That's a very good test because you can basically subtract everything out and just look at the vessels, and you can see the dynamic nature of contrast flowing in and out through the arteries and veins. CCMs typically do not show up on these tests. Cavernous malformations are low flow vascular malformations, and as such, we don't expect to see them on these. You may have had one of these studies, however, if the initial cause of the bleeding was unknown. It would be very common to get a CT angiogram, MR angiogram, or even catheter angiogram in a case of bleeding where the cause is unknown. Potentially if there's concern for something else as well. Perhaps a high flow vascular malformation needs to be excluded, or there's concern for an aneurysm or something along those lines. I should note that the developmental venous anomalies that we were discussing can be seen on these studies, although those are pretty well demonstrated by other studies such as the regular MRI sequences that Dr. Hart was mentioning. One other study you may hear about are nuclear medicine studies. The most commonly performed is a PET-CT. In a nuclear medicine study, a substance is injected intravenously. That substance then goes into your body and emits energy, which is then captured and imaged. It creates very noisy images, but it gives you some important information on physiology. Would not routinely use it for CCM imaging, can potentially be used in epilepsy imaging. And in fact, these images are from a patient with a CCM and secondary epilepsy. This is a PET-CT, and this is from the same study, a kind of projection or summation of all that data. And it was being used to try and figure out where the seizures are coming from and to help plan therapy for that. One other study you've probably heard about are ultrasounds. Ultrasound involves an imaging probe that's handheld, and that little probe emits sound, which then goes and bounces off structures, comes back, and then is processed by that probe to create some images. It's a relatively safe study, relatively inexpensive compared to an MRI. Since the skull in an adult is a complete bone around the brain, though, it's typically not very useful in the brain. So it wouldn't really be useful in imaging CCMs. This is an image here from a neonatal head ultrasound. So this is a newborn, and in a newborn that has an open fontanelle where the skull is incomplete, we can actually image the brain with that technique. Once that closes, there's not really that option. Very commonly used elsewhere in the body. This image here is imaging the kidney. Could conceivably be used in the operating room by a neurosurgeon, once they have the skull off and have the brain exposed. So some tests that you might encounter in preoperative planning are functional MRI and diffusion tensor imaging. Functional MRI, which you would consider to be task-based functional MRI, is a pretty long and time-consuming, tedious test that you might undergo prior to surgery. And the idea is to localize areas of functional activity in the brain. Typically, you would be given a standard series of tasks that you would do while the imaging is being done. Examples might include tapping your right index finger, then tapping your left index finger, then doing various verbal tests or reading type tests. And the computer is able to capture small amounts of signal change in the brain areas that are being used during these tasks, and that can be modeled and then secondarily placed onto the MRI. This can then be taken to the operating room, and they can know that certain areas of the brain are associated with certain functions, and they can try to avoid those areas. This pretty image here is from diffusion tensor imaging. It's a particularly fancy long imaging sequence that interrogates the movement of water in the brain and can be used to create a computer model, essentially, of all the connections in the brain. We can superimpose this on the more structural brain images, and then the surgeon can use those in the operating room to see where particular connections in the brain are and to try to avoid those areas. So as mentioned, would really be useful in particular CCMs if they're in an eloquent area or high-risk territory that the surgeon feels that it would be best to have one of these studies done before going to the operating room. Some institutions do use different tests than fMRI. One alternative you might hear about is MEG, or magnetoencephalography. Similar idea. The idea is to try to localize functions in the brain. We would not be doing any of these sequences on routine diagnosis or following up CCMs. I want to go over a few different imaging techniques that are in the realm of research. These are not things that we do clinically at UNM for imaging CCMs. One is permeability imaging, initially done at UNM and in CCM patients. And basically this image is very slow leakage of contrast, which does occur in cavernous malformations. It's a fairly long sequence. There's a lot of processing involved. Currently, we're not doing this at UNM except in the context of the CASH trial readiness study. So that's the cavernous angioma symptomatic hemorrhage. It's a multi-institutional study, and we're one of the clinical sites. So we will do permeability imaging in the context of that study. We're not processing them at UNM or using that information for anything currently. Similarly, quantitative susceptibility mapping, or QSM, is a research technique. We're not using it clinically at UNM. It is being done as part of that CASH trial readiness study. And I would think of that as being similar to susceptibility weighted imaging, except that it allows quantification of iron content. And since iron is in blood, the idea is that cavernous malformations that have bled are going to show increased iron content. Lots of heavy processing involved in that as well, and not something we're planning on doing clinically anytime soon. Another thing we've been working on are automated lesion detection, or essentially automated counting of cavernous malformations. Dr. Hart and I both worked on this within the context of the Brain Vascular Malformations Consortium study. We annotated a whole bunch of research scans, and then some of the scientists at UCSF helped with this and developed an algorithm that tries to basically flag small cavernous malformations. As many of you know, particularly familial CCM patients can have many, many hundreds of lesions. And when you have a lot of lesions, it's very, very difficult to count. Some of them are very, very tiny, sub-millimeter little dark spots, and very, very tedious. Dr. Hart and I have counted many together, and the counts are never going to line up exactly. And when we've done this with the computer is not exact either. Me and Dr. Hart tended to agree more together than we did with the computer, but the initial idea here was that we showed that the computer algorithm would correlate. So if I say there's a lot of lesions and Dr. Hart says there's a lot of lesions, the computer will also agree there's a lot of lesions. Lots of work to be done here, something we're going to be working on for many years probably before it's ready to be taken into clinical use. All right, wanted to go over a little bit how we approach CCM imaging and interpreting and reading these studies. So first off, I think the most important question is the finding consistent with a cavernous malformation? It should be noted that there are other things that can look like cavernous malformations, and that sometimes cavernous malformations can be obscured by bleeding. This is mostly a concern kind of in the initial diagnosis if someone has a hemorrhage that's unexplained. Sometimes a hematoma can look very, very much like a cavernous malformation. So you might think there's a cavernous malformation, and then months down the road after the hemorrhage has evolved and mostly gone away, it might no longer look like one. Same can be true where a hematoma can obscure a cavernous malformation. It may just look like a hematoma initially. And then as it kind of matures and evolves, you might be able to see the underlying cavernous malformation that caused it. Most cavernous malformations have this particular, very characteristic popcorn or mulberry type appearance with dark signal along the periphery. Those are pretty recognizable as a cavernous malformation. The very tiny cavernous malformations that we see pretty commonly in the familial type, those look like a lot of different things that can have that appearance. And in fact, if you were to take kind of all comers, even in our practice where we do see a lot of familial cavernous malformations patients, if you just see those little tiny lesions, it's probably more likely to be something else. Little tiny bleeds that have happened for other reasons, such as having high blood pressure or any number of other conditions, will create these little dark spots. So I typically like to see at least one kind of proper cavernous malformation that's characteristic and recognizable before I start thinking that all these little dots that we're seeing, or a few little dots that we're seeing, are cavernous malformations. That can be a little bit tricky. It's kind of hard to know when to think that they're cavernous malformations and not some other more common cause of dark signal. Then one very important question. So we have a cavernous malformation. Are there multiple? If we find multiple cavernous malformations that are not explained by a developmental venous anomaly, then we're essentially in the territory of a presumptive familial diagnosis. Other critical features that we want to assess with a cavernous malformation: is there any evidence of recent bleeding with the cavernous malformation, or if there's multiple, which one looks like it's had recent bleeding? Where is that lesion? Could it explain the patient's symptoms? We really need to target down where in the brain bleeding is if we're going to be able to attribute symptoms to it. Is there edema in the surrounding brain? So I would think of edema essentially as being the reaction of the brain to the bleeding. Is there significant mass effect related to the cavernous malformation and associated bleeding? And then are there any complications of that mass effect? So large bleeds in the brain can push the brain. It's called herniation, where you essentially push the brain over or down into areas it's not supposed to be. And then the ventricular system, which is where the fluid is in the middle of the brain. If there's a lot of mass effect, it can potentially obstruct the flow of that. So something else we want to think about. Other features that we're evaluating on CCM imaging. Are there any new CCMs since the prior MRI? Not something we would expect to see in a sporadic case, but very common in familial cases. We know from following familial CCMs over time that it's very common to develop new little lesions. Has the CCM grown? So, that could be explained by a recent hemorrhage, but we do see where they just grow in size. Is there any other change in appearance that could potentially be important? And then other things that we would look for on any MRI. Any evidence of a stroke, signal changes in the white matter that we very commonly see, any atrophy in the brain, mass effect, or something else unexpected. All right, so we wanted to take some time to address some common questions or concerns that we hear about, and then there'll be some time for other questions. So we hear commonly that there are differences in number of lesions reported to patients. As Dr. Hart was mentioning, there's a whole bunch of different factors that can lead to the differences in the number of cavernous malformations that are visible or that are counted. Some of these little tiny ones are extremely subtle, and it's very hard to know kind of when to count it versus when to think that it may just be some subtle heterogeneity in imaging. We tend not to count the exact number or put that in reports on follow-up imaging. And on follow-up imaging, we will focus on change in lesions, in new lesions as being the most important things. Differences in interpretation or wording. So cavernous malformations can be confusing, especially as I mentioned in the setting of an initial bleed. Compounded on top of that, there's the fact that they go by many different names. I'm sure you've heard many of them. Cavernous malformation, cavernoma, cavernous angioma. Sometimes you'll hear someone say cavernous hemangioma, which we try to stay away from. Cryptic malformation, you'll sometimes hear referring to the fact that they're not seen on angiography. And I would say that the kind of classic popcorn appearance of a cavernous malformation is going to be very recognizable and something that I would expect most radiologists to be very familiar with and recognize as a cavernous malformation. That being said, we all know what we see very commonly. So, Dr. Hart and I do image a lot of familial cavernous malformations patients. So, we're very used to calling the little dots that we see on susceptibility weighted imaging to be small cavernous malformations. If someone has not seen a lot of those cases, they might not consider those to be small cavernous malformations. They might end up putting them in a category of just being small dots on susceptibility or being another cause of microhemorrhage, or they might simply just refer to them as microhemorrhages. One other confusing concept is the concept of bleeding. So a hemorrhage event or a symptomatic hemorrhage has been defined within cavernous malformations to be a clinical event with symptoms that is then supported by imaging. That means it is not defined just by imaging findings alone. So you can have a mild change in lesion appearance on MRI. You can even see a little bit of increased blood on MRI or new lesions on MRI. And that does not necessarily mean that you had a hemorrhage event or a symptomatic hemorrhage. So the MRI report might say that there's a new cavernous malformation, or this lesion has changed, or there's a little bit more blood. But that really needs to be interpreted in the clinical context of, do you have new symptoms or not, before you would say there's been a hemorrhage event or a symptomatic hemorrhage. I know that's a confusing concept, but I do think that leads to some sort of disconnect sometimes between what the findings and impression were on the MRI versus what might be going on with you clinically. So at this point, we wanted to open up to questions, and Dr. Hart, feel free to.
I want to just mention, very briefly,
No,
if I could.
go on, Dr. Hart. I'll get your questions as soon as you've made your comment. Go on.
Very minor comment that in regard to new lesions with sporadic, it is possible to have more than one cavernous malformation around the periphery of a single DVAS. So if you got these branches, you might have one in one place, one or another, and it is possible sometimes to see a new one appear. It'd be pretty uncommon. It would be in a close, similar location. That's a pretty minor point.
Okay. All right, we have a bunch of questions that have been stacking up, so I'm really excited to get started on asking you them. And I apologize if any of them were already in the presentation, but I think most of them bear repeating if they were. The first one is for someone who writes, there was a lot of edema after my hemorrhage, and they wanted to know, in regard to edema, can it temporarily or permanently damage healthy brain tissue? After the edema resolves, do you still see some impact where the edema was on the brain tissue? And you can pick whoever wants to answer it. Dr. Mabray, you're muted.
Mark, do you want to address that?
Sure, and that can be hard to tell or hard to answer. There are varying degrees of edema. I would think that if it's kind of just mild edema or reaction in the brain, then sometimes we do see that go away. If it's quite severe and has affected quite a lot of the brain, particularly with mass effect, we do see more significant and permanent type injury in the brain parenchyma in those settings.
Thank you. Someone else has asked, is it common to have more than 100 cavernous malformations?
So I can give you a number. I looked up this morning, just a couple hours ago, in our database, and about 15% of our patients had over 100.
Okay, and that's 15% of people with familial cavernous malformations.
Familial, and that was in the BVMC study group.
Okay.
So, not real common, but certainly not rare.
Okay. Next question. How often should an MRI of the brain be repeated in a patient with cavernous malformations but no symptoms? I know that's a tricky question.
That is a tricky question. I don't think there is a very clear answer. It's going to depend to some extent on the judgment of the neurologist or neurosurgeon who's following the patient.
I think what I've heard other physicians mention is that looking at the history of the patient makes a big difference. And so since everybody has a different history, it really turns into being an individualized answer.
I think things in the future, there may be a very different answer in the future once we have medical treatments. Yeah. Because then we'd have the MRI would have some use as a tool to follow the results of a treatment. Otherwise, symptoms are important in the patient's history.
Yeah, and we're also looking forward to blood biomarkers, which would put you out of business, but not completely.
Right. Okay. Could be a very helpful supplement. That's right.
Could be. All right, next question. You mentioned that gadolinium has some impact, could have some potentially negative impact if there's a person has compromised kidneys. But is there any other potential unsafe thing going on with gadolinium? We've read things.
Right. So this is a hot question the last few years because, first of all, straight gadolinium is poisonous. It's toxic. And so when the gadolinium is injected, it's always attached as part of a molecule that binds it very, very tightly, and the kidneys get rid of it. But what's complicated things is that we have learned in the last few years that a small amount of gadolinium can remain in the body and in the brain. People have been looking at this question very, very hard. So far, we don't know of any harm that it causes. It seems to remain tightly bound. It's a small amount, but it's there. And so all I can say is at this point, like anything, any test, probably wouldn't do it if there's not a good reason. If there is a good reason, we don't know of any harm.
And our general approach is if there's a strong reason to give gadolinium contrast, then we do it. But if there's not a strong reason to do it, then there's no need to kind of take that theoretical risk.
Okay, thank you. All right, next question. Dr. Hart, you mentioned that there's the potential risk with CT scan of causing perhaps the development of new lesions. This person is asking whether CT scan on an area of the body other than the brain, for example, if they had a lung CT, could that have any impact on the brain?
I think the answer is no, that it would be a direct result of radiation to the brain.
To the brain.
Well, the most dramatic example I can give is that we saw a patient who had radiation therapy that happened. It was actually for a cancer in the nasopharynx, the passage behind the nose. And so there was some overlap with part of the brain. And we could see that although there were some, this is a patient with familial form, there were some cavernous malformations scattered throughout the brain. It was very easy to see where the radiation field was. It tends to be in straight lines because there were many, many more within that field. But CT to the lung should pose no damage, no risk to the brain.
Next question. Is there any role for an open MRI in either the diagnosis or monitoring of cavernous malformations?
I would think only if that was the only way to get an MRI. The open MRIs, my understanding is they tend to be lower field strength magnets. So they're going to be less sensitive, particularly to the detection of the small ones. But for various reasons, that might be the only option for some patients. And in that case, it's probably going to provide more information than a CT alone would.
Thank you. Next question. You mentioned that a CT is really good for seeing fresh, recent bleeding. How long does that remain true? At what point is the MRI just as good as the CT scan, or is it no longer possible to see fresher bleeding on a CT scan?
Acute blood on a CT tends to fade and become closer to brain density, in fact, even less dense over time. It takes roughly 2 weeks for that process to occur, and a large hemorrhage might take even a couple of months for that to fade. MRI is very sensitive very early.
So the advantage of the CT then is the speed and the ease of the imaging rather than what you can see when somebody comes into the ER.
Yes.
Okay.
And CT certainly has a role for ruling out kind of surgical emergencies very quickly. Is there a very large hemorrhage? Is there a lot of mass effect? But even if the CT doesn't show anything, most of our patients are going to go on to get an MRI soon to follow.
Yeah. Okay. This is a question I'm not sure you can answer, but what do you do if your doctor doesn't know what an SWI scan is? Can you maybe just mention some of the alternate names that other manufacturers use?
SWI is a Siemens term, although it's also kind of a generic term, but specifically susceptible weighted imaging is used by Siemens. GE uses what they call SWAN, all capitals SWAN. Philips uses Vino Bold, I think, something like that.
Yeah. Okay, so perhaps that would help if you go through the list of names.
And whatever imaging center you were to go to, the radiologist or the radiology technologist, MR technologist performing the scan should be familiar with these sequences and what the similar type sequence might be on their particular scanner.
And just a plug for the Angioma Alliance Centers of Excellence and CCM Clinical Centers, that's a requirement. If you're visiting one of those, that you have your MRI on a 3T machine and that it be performed with an SWI sequence. So that's a reason to go there, is because it just is part of the normal protocol. Next question. If you have a frontal lobe cavernous malformation and you have been told that it's not familial, should you still get your spine checked just to make sure? You mentioned that one case of the young boy who had the spinal lesion and only one lesion in the brain.
If it's truly familial, I don't think there's a reason to look at the spine.
Okay.
Or truly sporadic.
Sporadic, yeah. Yeah.
Right. If it's not familial, if it's truly sporadic, and that's more likely if you see it with a DVA. Now, sometimes you don't always see a DVA. So if you find one lesion, that leaves to the question of you've done the SWI, for example, then you have the question of what other things should be done. Obviously, family history, genetic testing sometimes.
So I think too, now there's some hesitance, and this is sort of a follow-up question, to even do spinal MRIs on people who have familial if there's no symptoms, because frequently there's not a whole lot you can do anyway. So, I don't know if I'm sure at UNM, because everybody's in research, that's probably not the case, but in other institutions, folks have been deferring on spinal imaging. Okay, next question. Somebody just wants to know exactly what they should be asking for. Like, can you spit out that whole series of letters when you're asking for a 3T MRI with SWI and with or without contrast gradient, whatever? What is it that they should be asking for when they're going in?
The most sensitive would be done on a 3T magnet with SWI or equivalent. There's no reason for routine imaging to use gadolinium. Often that would be done on the very first scan, for example, but not necessarily on follow-up scans. But the best would be to make sure that it's done on a 3T with SWI.
Next question. Can surgery make it more difficult to see things on MRI? For example, someone had spinal surgery, they had a resection, then they had a recurrence of symptoms, and it was thought that maybe there was a regrowth of the lesion, but because there had been already the spinal surgery, the person said that it wasn't very clear. Is that typically the case? Dr. Mabray, you're nodding.
Yeah, I think after surgery, the appearance can be very confusing sometimes. The dark signal that we see with cavernous malformations, which is from the iron in blood, often persists. And, I personally think it can be very hard to tell if there's cavernous malformation still there, because you're still seeing imaging findings of where it was. And then, you mentioned the spine. A lot of times there's hardware in the spine too. And that can make it very difficult to even see in the region.
But one thing I've noticed on my daughter's MRIs is the term blooming artifact. What is that?
So on the gradient recall sequence, it's more sensitive for blood, but it's also more sensitive for any kind of metal. And so if there's hardware, that gets a lot, it seems that the effects are exaggerated with the gradient recall sequence. And also the areas of blood, they look bigger on a gradient-based sequence. That makes it more sensitive to pick it up, but it can be confusing for the size. We keep emphasizing over and over these blood-sensitive sequences, but in fact, the regular non-supersensitive sequences are better for measuring size because they don't have that blooming appearance.
That's a very good point to keep in mind when measuring these things. The most important statement to me is that a lesion has not changed, more so than the measurement given in millimeters. Depending on which sequence someone were to measure one of these lesions on, the size can be quite different. You get a whole lot of blooming artifact on the SWI type sequences that make it look a lot bigger than it truly is.
And they're often not perfectly round, so where you choose to measure it will make a difference in the number.
Next question. The questions are pouring in. Do you guys have a hard stop at the top of the hour? Do either of you need to leave? Okay, then if we go over a little bit. A lot of us have had situations where our MRI report has come back saying that it could be either a cavernous malformation or an AVM. Do they look different on MRI? Can you tell the difference on MRI?
Well, the classic is yes, the AVM looks like a tangle of blood vessels, but small AVMs might be difficult to separate out. And the question of AVM is the one setting where it might be helpful to have the blood vessel imaging Dr. Mabray talked about, and sometimes even a catheter angiogram. So larger ones, usually we can tell apart. Small ones might be challenging.
Okay. Question is, I'm not sure if I'm going to ask this correctly, but they're wondering about CCMs being visible on MRA. Are they visible on MRA?
You can sometimes tell that they are there because they have some intrinsic signal that will be visible on there, but that is different than them actually having arterial flow that's creating the MRA image. So yes, you can see them, but it wouldn't, the significance of that is not much. So I would kind of think of it that most cavernous malformations, no, I would not see them. But if they happen to have kind of very bright signal that is shining through kind of the background of the imaging, then I will be able to see them there.
Next question is, can you see oozing? When people say, I've had an ooze, is that visible on MRI? And they're asking specifically for familial, but I think, that truly what people hear from their doctor is usually, we understand you've had symptoms and you may have had an ooze or a microbleed. Is that something you see, or is that just something they made up to explain the symptoms?
Well, sometimes we see it. Sometimes we can see an increased amount of blood within a cavernous malformation. And to some extent, the black rim around there is due to previous oozing, and the remnants of the blood that's broken down causes that black rim around the outside. So we see that, and internally sometimes we see more blood. For example, sometimes we might even see a layer, a horizontal layer of red blood cells layering on the bottom, and then different forms of blood on top. So sometimes we get clues to that.
Okay. This is sort of along the same lines, but if you had a bleed a long time ago, this person said they thought they had a bleed like 3 years ago, would that be something that you could still know when you look at their MRI? If 3 years later that they might have had a hemorrhage in the distant past?
Well, you'd probably see something, but it may be difficult to know how long ago.
Okay, so dating it would be a problem, but a yes or no would probably be possible.
Yes.
Okay. Um, Again, this is one I'm not sure you can answer, but they want to know whether CCM can cause cerebral atrophy.
It could cause some local atrophy. I wouldn't expect it to cause atrophy of the entire brain, but there might be some local damage that might cause some atrophy.
And then I think other people on their MRI reports often see something called encephalomalacia or encephalomatia. I'm not sure I'm pronouncing it correctly, but is that something you see maybe post-surgically a lot?
Yes, I mean, that's something you'd see after surgery. And sometimes, for example, if you had a large hemorrhage, you might be left with some encephalomalacia. That's the long, fancy word for damage that's caused part of the brain to go away.
Okay. What is tractography and why would it be used?
Mark?
Sure, I can actually, let's see if I can go back. Tractography is this big conglomerate of connections which are called tracks. So tractography would be doing this diffusion tensor imaging sequence and then making models of the tracks of the brain. And that would be something that would be used usually in the preoperative setting to have essentially a map to take to the operating room.
Okay. And then someone asked about MRI being used during surgery. Do you see that? How does that work?
We do not have that at UNM. I was a resident and fellow at UCSF when they installed an intraoperative MRI machine. And it was essentially a hybrid type operating room that has an MRI connected to it. And in those cases, they might do some preoperative imaging. And then at a certain point during the surgery, they might go back and do some more imaging. The idea being that they could kind of check the progress of the surgery and, particularly for tumor type cases, see if there's more resecting to be done. In that setting, it was not used real frequently, so a lot of times it would be used essentially as a regular MRI the rest of the time.
I mentioned that mapping is frequently used now using a detailed MRI beforehand, and then the surgeons can use that during the surgery to help guide them. So they can actually, move a needle and see in space where that is relative to the MRI. So the advantage of the intraoperative MRI is they can actually look at changes as they go along. Tends to be used more for probably tumors than cavernous malformations, but they can get operative guidance with the MRI now.
Yeah, that's a great point. So this image or 3D volume of information can be registered to the patient in the operating room by using a fancy computer navigation system. So for example, they would touch a probe to the nose and register we're on imaging, and then the ear or a few different landmarks. And they can basically know and project on the image that my probe or instrument is right here. Now it's here, and now it's here. So our approach has really been to get all this stuff done beforehand and then send it to the operating room to use instead of the approach of kind of in the operating room. I should mention that, places that are doing intraoperative MRI, they're not redoing all these fancy sequences at the time of surgery. They're doing more sort of limited structural imaging to check the progress of the surgery.
Here's a big question. Is it possible to tell from an MRI whether a lesion is more or less likely to hemorrhage?
Some of the research tools we hope will give us an insight, maybe those blood tests you're talking about right now. We'd hope, for example, that the permeability imaging might give us some clues that it has not worked out as well as we'd hoped. Right now, the biggest clue is simply the behavior over time. If it tends to, once it's bled, it's more likely to rebleed. And if it bleeds twice, then it's probably more unstable.
And that is certainly one of the long-term goals, particularly of the CASH trial and some of these things developing. Wouldn't it be great to have a biomarker of some sort that tells you this lesion is likely to be active, or this is a more dangerous lesion here than the lesion over there. So that would be great if we can figure that out someday.
I'm going to ask two more, and then we'll stop. One is a follow-up from a previous. How long does blood from a cavernous malformation hemorrhage, I guess, stay on an MRI? Is it forever?
Some of it may be forever. It's very complicated on MRI. And the early changes take a few days. We can see changes that last several weeks. And then the dark areas that rim around the outside can last for years.
And then the last question I think I have for you, and those of you who asked some questions that we didn't get to, we'll try and get back to you later. I'm looking at them and trying to judge whether this is the right venue for them to be asked. The last question here is, what does it mean when someone says chronic hemorrhage on the MRI? What do you know that this lesion shows evidence of chronic hemorrhage, or if they're told that by their physician?
Usually that would be referring to the black areas around the outside.
And the chronic part of it is?
Well, that represents hemosiderin, which is the late form, and it gets deposited and laid down in the brain, and it can stay maybe throughout the person's life.
Kind of seeing the end stage of breakdown products with iron type signal, creating that dark appearance.
Okay.
Cavernous, the kind of like there's a classic description of the way blood evolves in the brain and some ways to kind of time that. But I will say that cavernous malformations seem to be much more complicated than that. And they don't seem to follow kind of these predictable patterns. So for example, these lesions have probably been there a long time, and there's this dark signal, essentially iron from old blood. And then these bright areas, they're actually, probably inside the cavernous malformation. It's chronic, it's probably been there a long time, but it's more complicated than just the blood signal.
Bright areas in most other causes of hemorrhage, we would say, oh, the bright area goes away within about a couple of 2 to 4 weeks, something like that. And yet it's clear that with cavernous malformations, those bright areas can last for months and months. So they are more complicated.
Yeah. Okay. Do either of you have any last thoughts or words or anything occur to you while you were answering questions that you didn't get out yet? No? All right.
Well, thank you.
Thank you. There are a number of the folks who are watching have posted to thank you, because this is really interesting. It's the first time we've done an imaging only webinar, and I think I've learned a ton just from sitting in. I think everybody else has as well. So thank you.
Welcome.
And it's wonderful. I'm sorry we won't be able to see each other this year at the science meeting, but I hope we'll be able to see each other virtually. I just, before we shut out, I just want to mention a few things that are coming up. First off, make sure you get Netflix and watch the series Away, because it features a character that has CCM very prominently. One of our members was a co-writer on the show. and did interviews, extensive interviews with our other members, used her own experience, and that was incorporated into the character of Hilary Swank's husband on the show, and it's gotten a lot of attention on our Facebook groups, but everyone who's watching, if you haven't seen it already, check it out. Secondly, later in September, we have a session with Maggie Whittam. It's going to be a meeting rather than webinar format to allow for discussion, but Maggie will be sharing her story of having a major brainstem hemorrhage and surgery, and then her reinvention of herself after that. We also have a spinal cavernous angioma support group, as well as our regular weekly general support groups. All that information is on our website. And then next month, mid-month, Dr. Issam Awad will be sharing updates from the atorvastatin trial. And then the last thing I wanted to mention is that October for us is going to be CCM Warriors Month, which means that we want to hear about the people in your life who have been battling and succeeding in the battle with their illness and with recovery and just going on. We want to know the special things that they've done. Share them with us. There's information about how to do that on our website. We want to put it on social media. We want to put it on the website also. And then at the end of the month, we would like to feature some of those folks in a video, a live presentation again, like as we had done in June. So lots coming up. I'm really excited. Lots of good science happening too. So thank you, everyone. Thank you, Dr. Mabray. Thank you, Dr. Hart. Have a wonderful rest of the week, and we'll hear from you again sometime soon. Thank you.
Thank you, everybody. I hope that was helpful.
Thanks.